All right, superb. So I think I can.
All right, superb. So I think I can. All right, superb. So
All right, so everything is perfectly fine. The audio is fine, the video is fine, and welcome to the second day of Orthopaedics Series. And yesterday we discussed about the fractures, basics, and the different complications and everything. Now, in this class, we will discuss about the upper limb fractures and the complications associated with upper limb fractures, right? So, of course, see the upper limb fractures are various many fractures. You name the bone, fracture is going to be there. But since we have to understand that, we can't remember everything, and these classes are meant for the purpose where we are supposed to figure it out that what is important and what is not. Let me just give you the brief idea, as in which all what all things are very important for today's class, and what all are just asked for the MCQ purpose. So this very first slide is going to be the list of topics. Okay. Yeah. So what are the topics which we are going to discuss today? So first of all, the very first topic is going to be the supracondylar fracture of humerus. Okay. Supracondylar fracture humerus. Then next we will discuss about the Colles fracture versus Smith's fracture. Then we'll have Bennett's fracture, Monteggia fracture, Bennett's Monteggia, then Waxman ischemic contracture, wrist drop, and cock-up splint. All right, wrist drop and cock-up splint. So these are the 5, 6 topics which we are going to discuss in a great detail. Of course, one more very important topic, shoulder dislocation. And in shoulder dislocation also, the very important part is the anterior shoulder dislocation. Okay, anterior shoulder dislocation, that's again an important thing. Okay, then for some so these are the topics in detail, in depth we will discuss. I'll also give you a brief idea about some MCQ topics like the Bennett's fracture, sorry, not Bennett's, Bencart's lesion, Hill-Sachs lesion, because if I talk for the shoulder dislocation, these lesions are also important. The Bencart's lesion, the Hill-Sachs lesion. All right. Then we will have the pulled elbow as a topic, pulled elbow as an MCQ topic. Then Gigliazzi's fracture, boxer's fracture, and then the other two important fractures are not fractures but mallet finger and Jersey's finger, more or less fracture only, mallet finger and Jersey finger. Okay, and then two important parts, the tennis elbow, golfer's elbow, tennis elbow, golfer's elbow. Okay, and yes, I'll try to include one more topic, that is your rotator cuff. Okay, okay, this I'll tell you what I mean, if I'll be able to do this or not. Okay, so these are the MCQ points. Now, there are some overlapping topics with anatomy. Okay, there are some overlapping topics with anatomy, like the brachial plexus and injury. Okay, brachial plexus and injury associated with brachial plexus. Then nerves. Okay, so nerves as in the median nerve is there, The radial nerve is there. Okay, radial I'll teach. Ulnar nerve. Okay, and similarly rotator cuff and its tear. Okay, rotator cuff muscles and its tear. Okay, so these topics. Okay, and one more topic of interest: frozen shoulder. Okay, frozen shoulder. So these are the different topics, okay, which we are going to discuss in today's class. So I've given you the list of the topics. Okay, these are the list of the topics which we'll be going through. Anatomy topics, of course, I'll have to check, like if I'll be getting the time, I'll be taking the anatomy topics, and if not, then we will skip it and will request the faculty, okay, the faculty of your anatomy to take over these topics, right? So these are the different topics of interest. We will, uh, okay, we will deal with them today itself, right? Chaliye. So I think now we are in a very good position to start with the topics. But before that, as I always start these sessions with some case-based scenarios, let's quickly understand all these case-based things. Okay. Yeah. Okay. So side by side, yeah, I'm having this with me. Your comments also. So anything, if it is there, you can just comment down in the comment section, right? So coming on to the very first thing, see this. See this. 6-year-old boy falls on an outstretched hand. First of all, this is important. Fall on an outstretched hand, and we call it as a foosh injury. Foosh, okay? FOOSH. It's a foosh injury. Foosh means what? Fall on outstretched hand. Okay, foosh. So while playing and presents with pain, with swelling and deformity. So anywhere you see these type of words, the pain, the pain, the swelling and the deformity, okay, you have to understand that this is nothing but a fracture. Okay, so fracture is there, of course, and this is a foosh injury, of course. And the what you have to understand is that the radial pulse is also feeble. Okay, the radial pulse is also feeble. So what is the most likely diagnosis? So you can diagnosis is naturally the, and it's a 6-year-old boy also, so it's actually something which has involved the radial pulse as well. So it is around the elbow. So either it can be lateral, understand this now, either it can be supracondylar fracture humerus, either it can be supracondylar fracture humerus, or it can be lateral condylar or retroepicondylar fracture. I should say condylar only. So lateral condylar fracture humerus. Okay, right? So these are the differentials, although some other differentials can also come in. But now this is the very first topic of discussion, okay, where we have to understand that it's a pediatric child. So of course, one thing which you can understand is that supracondylar fracture is common in what, in the pediatric age group. Then what is the mechanism of injury? So this is the mechanism of injury: fall on outstretched hand, that is whoosh. Then it's pain, swelling and deformity, that means it's a fracture. And that is going to involve what? That is going to involve the pulse as well as a complication. Okay, so these are the very important things which I have tried and tried to tell you. Okay, so before we proceed further, I just want you to see this. Now see this, can you see, can you see there is a break over here? Yes, can you see there is a break over here in these two particles? And this is the, so this is the condyle, this is the area of supracondyle. So this fracture is called as SCH, or supracondylar fracture of humerus. Okay, supracondylar fracture of humerus. Okay, there is a supracondylar fracture of humerus which is there. And now it's the perfect time for us to start discussing the very first topic for today, that is supracondylar fracture humerus. Okay, supracondylar fracture humerus. Okay, so starting with the topic supracondylar fracture humerus. Okay, supracondylar fracture humerus. Chaliye. So, supracondylar fracture humerus, a very first topic of discussion for today. Just understand that this is, first of all, put a note that most common, it is the most common pediatric traumatic fracture resulting from fall on outstretched hand. Okay, so supracondylar fracture is the most common pediatric traumatic fracture that results from FOOSH or fall on outstretched hand. Okay, or fall on outstretched hand. Okay, so let's understand. So this is more or less a definition. Now we will discuss about the pathophysiology. Okay, let's understand about the pathophysiology. So pathophysiology, see, of course, as I've told you, it's most commonly seen in children. So you have to understand that what is the age group. The age group which in which it is common is approximately 5 to 7 years. So just remember FOOSH. So it has got 5 letters. So 5 letters means age group is approximately 5 to 7 years in which this is very common. Although more common is male in male. इक्वली कॉमन इन मेल एंड फीमेल. वाई? बिकॉज इट्स अ ट्रोमैटिक फ्रैक्चर. and कोई भी चीज अगर ट्रॉमा की वजह से हो रही है तो उसमें जेंडर प्रीडिस्पोजिशन नहीं आता. Okay, right. Now one thing which you have to understand is that this is happening because of fall on outstretched hand. Okay, it happens because of fall on outstretched hand. And in that region, just understand that the in that region, so for example, if I just draw this supracondylar, this region, okay, I'm writing, there is only a thin cross section of bone in this region. There is a thin cross section of bone in this region. Okay, there is a thin cross section of bone in this region. Okay, and these are the two most important mechanisms which are responsible for supracondylar fracture of humerus. Okay, coming on to what are the associated injuries. Okay, coming on to what are the associated injuries. So when I talk for some associated injuries, please understand one is going to be neuropraxia. The nerves are going to get involved and that is called as neuropraxia. Now what does this term literally means, neuropraxia? We will discuss when we will study about the nerve injury, but as of now just understand that there is neuropraxia. Now, neuropraxia can involve four nerves. One is going to be anterior introitious nerve, which is a branch of median nerve. Anterior introitious nerve. Okay. Please remember, anterior introitious nerve is the most common nerve. Okay, anterior introitious nerve is the most common nerve which is involved. Then comes the radial nerve. Then comes the radial nerve, and please remember that radial nerve is the second most common nerve. It is the second most common nerve which is involved. So radial nerve is the second most common nerve. So please understand A for alphabet. क्या होता है? A से क्या होता है? A for apple, and A is the first letter in the alphabet. So anterior introitious nerve is the most common. Radial nerve में जो A है वो कहाँ आ रहा है? Second position पे, इसीलिए it is the second most common nerve which is going to be there. Okay, and then can it involve ulnar nerve? Yes, ulnar nerve can be involved with the, it is involved with the flexor type of injury. Okay, it is involved with the flexor type of injury. So when flexor type of injury is there, then ulnar nerve can be seen to be involved. Okay, it can be seen to be involved. So one is the neuropraxia. After neuropraxia, the next important thing which can be associated is called as vascular injury. Okay, it is called as what? It is called as vascular injury. So these are the pathophysiology also, these are the complications also. Okay, coming on to vascular injury. So vascular injury means, please understand that there are chances of vascular injury, but what we have to understand, that aberrant collateral, okay, simply writing collateral blood supply can help. Okay, Collateral blood supply can help in maintaining the blood circulation. Okay, very rarely, okay, rarely, but associated with the ipsilateral distal radius fracture also. Associated with ipsilateral distal radius fracture also. Okay, ipsilateral distal radius fracture also. Okay, coming on to the next part, that is called as clinical features. So what are the clinical features associated with supracondylar fracture of humerus? So first clinical feature is going to be, of course, pain, because it's a fracture. Then it is going to have swelling, and yes, the patient will refuse to move the elbow. Refusal to do the elbow movements. Pain, swelling, and refusal to do the elbow movements. Okay, pain, swelling, and refusal to do what? To do the elbow movements. Okay, then these are the different signs. Oh, sorry, these are the different symptoms the patient is going to complain of. And when you look out for different signs in it, just remember on examination, there will be gross deformity. There will be gross deformity which can be seen. Okay, gross deformity. After that, you will have, of course, swelling will be there. There will be ecchymosis in the antecubital fossa. Okay, in the antecubital fossa, there is going to be ecchymosis. Ecchymosis in the antecubital fossa is going to be there. Then you will have puckering sign. Now, what do you mean by puckering sign? Okay, let's understand about the puckering sign. Okay. So if I ask you about the puckering sign, please understand puckering sign means, so whenever you are going to palpate or look out for brachialis muscle, the brachialis muscle is going to indicate the proximal fragment buttonhole, okay, through the brachialis. So the proximal fragment, understand this, the proximal fragment, okay, it indicates proximal fragment that will be buttonholed, okay, that will be buttonholed, okay, in the brachialis. So there is a puckering sign which is there in the brachialis muscle. Okay, brachialis muscle. Then we have to understand that we should perform the neurovascular examination as well. So neurovascular examination has to be performed. Okay, and what you will do in the neurovascular examination, please understand, one is anterior introitious nerve neuropraxia. Okay, anterior introitious nerve neuropraxia has to be taken care. And what will you do in anterior introitious nerve? So flexure pollicis longus will not be able to flex the interphalangeal joint of the thumb. So flexure pollicis is always thumb. Okay, flexure pollicis longus can't flex. Okay, can't flex the interphalangeal joints. Can't flex the interphalangeal joints of thumb. Okay, interphalangeal joints of thumb. That's why there is an anterior introitious nerve neuropraxia. So F for flexure, can't flex. P for phalangeal, so interphalangeal joints of the thumb. This is anterior introitious nerve. Okay, interior introitious nerve. Also, flexure digitorum profundus is also gone, and since it is gone, you can't flex the index finger. Okay, interphalangeal joint of the distal interphalangeal joint of the index finger. So index finger distal interphalangeal joints can't be flexed. So very simple to understand. Digitorum profundus, DP, DIP, and F for flexion, F for flexion. So index fingers, DIP, can't be flexed. Okay, right? And yes, this is the volar aspect. Okay, this is the volar aspect. So loss of sensation over the volar index finger, loss of sensation. Okay, loss of sensation over volar aspect of index finger. So volar aspect of index finger, there will be loss of sensation that is going to be there. Okay. After that, you have got radial nerve neuropraxia also. This is anterior interosseous nerve. And then you have got radial nerve neuropraxia as well. So what will you see in the radial nerve neuropraxia? There will be wrist drop. There will be wrist drop, as you can't extend the wrist properly. Okay. Then you have to understand about the these are the nerves. And then if I talk about the vessels, then of course the vessels, if it will be compromised, there will be cold, pale skin. Okay. With artery refill time more than 2 minutes, sorry, more than 2 seconds. Artery refill time more than 2 seconds. Okay. If there will be the compromise of what, if there will be the compromise of, Hanji, if there will be compromise of what, there will be the compromise of your vessels as well. So if the vessels will be compromised, you will watch this. Okay. Coming on to, so this was the supracondylar fracture clinical features. After that, we will discuss about the classification of the supracondylar fracture. Now we will discuss about the classification of supracondylar fracture. So now we will discuss about the classification of supracondylar fracture, and the name of the classification is Gartland classification. Okay, it is called as what? It is called as Gartland classification. Now Gartland classification is based upon it is based upon the position of the parent bone and the fragment which has been broken. Okay, it depends upon the parent bone and the fragment which is broken. So what it is, let's understand. So basically they tell you like this: flexion type of deformity, extension type of deformity. So just remember, extension type of deformity is the most common one, approximately seen in 95% of cases, and flexion one is only seen in the 5% of the cases, and flexion one is only seen in the 5% of the cases. Now please understand the types of the fracture. So you have got type 1, type 2, type 3, type 4, and then comes the flexion type of deformity. Okay, so type 1, 2, 3, 4, and flexion type of deformity. So what about type 1? Type 1 means that it is an undisplaced fracture. Type 1 means that it is an undisplaced fracture. Okay, type 2 means it is displaced fracture. Okay, it is displaced fracture but in one plane only. It is displaced fracture but in one plane only. Okay. Type 3 is displaced in two or three planes. Okay, displaced fracture in two or three planes. Okay, and then you have got type 4. This is the complete periosteal disruption. Understand, it is the complete periosteal disruption. Okay, complete periosteal disruption with instability in flexion and extension, with instability in flexion and extension. So there will be instability in flexion as well as extension, and complete periosteal disruption will be seen. After that, flexion is again important, where the mechanism of fracture or injury is fall on olecranon process, okay. So in one, it is of course undisplaced, and two, three, four will be displaced fractures, but in all of them, there will be extension type of injury which will be there. There will be extension type of injury which is going to be there. Okay, extension type of injury which is going to be there. Okay, now understand that three, where you have a displacement in second and third, I mean in two or three planes. So it has got two things. Now 3A is there, 3B is there. So 3A means what? There is posteromedial dislocation. There is posteromedial dislocation, and 3B means what? Posterolateral dislocation. Please understand, posteromedial dislocation, M for medial, M for most common. So it is most common. So posteromedial is most common, and then the posterolateral dislocation. And this is all about the classification. Okay, this is all about the classification. Coming on to the radiological aspect. Okay, coming on to the radiological aspect of, okay, coming on to the radiological aspect of the supracondylar fracture. So what will you see in the radiology? There is a sign which is called as posterior pad of fat sign. So this is just the name you have to learn. Okay, posterior pad of fat sign. Okay, posterior pad of fat sign. Okay, so this is one thing, posterior pad of fat sign, which is going to be there. Then there is something which is called as displacement of anterior humeral line. Displacement of anterior humeral line or humeral line. Okay, so there is displacement of anterior humeral line which is going to be there. Okay, so normally what happens is the anterior humeral line intersects the middle third of the capitulum. Okay, normally it is this. Now what happens, the capitulum is going to move posteriorly to this reference line. So if it is moving posteriorly, this is extension type, and anteriorly in the flexion type. So you have to understand there is a line which is called as anterior humeral line. So anterior humeral line is something that is going to intersect the middle third of the capitulum. It is going to intersect the middle third of the capitulum. So boss, just understand that, anterior humeral line. Okay, all right. Anterior humeral line intersects the what is going to intersect? It is going to, anterior humeral line is going to intersect the medial third of capitulum. Okay, but if the capitulum moves anteriorly, it is the flexion type of the injury, and if it is going to move posteriorly, it is the extension type of injury. It is which type of injury? Extension type of injury is going to be there. Then you have something which is called as Bowman's triangle. Then there is the concept of Bowman's angle or Bowman's triangle, whatever you can call it as. Okay, so what do you mean by Bowman's line? So Bowman's line is a line which is parallel to the longitudinal axis of the shaft of the humerus. So if I just make the shaft of the humerus, for example, this is the shaft of the humerus, and if I draw a line, this is called as Bowman's line, a line which is which is parallel to the, so this is Bowman's line which is parallel to the, okay, line. Bowman's line is a line which is parallel to the longitudinal axis of the bone. Okay, parallel to the longitudinal axis of the bone. Bowman's line is the line which is parallel to the longitudinal axis of the shaft of the humerus. Okay, and there is a line. Okay, and there is a line which is going to along the lateral condylar epiphysis or lateral condylar physis. Okay, lateral condylar physis. So for example, this is the lateral condyle. So there is a line which is going to go lateral condyle to the physis like this. Okay, so the angle which is formed in between both of them is the angle alpha, and this angle alpha is called as what? It is called as Bowman's angle. Okay, this is called as Bowman's angle. Okay, it is called as what? Bowman's angle, which is approximately 75 degrees normally. Okay, 75 degrees normally. So if of course the lateral condyle or this part is fractured, the Bowman's line will get disrupted, and then the Bowman's angle is also going to get disrupted for sure. Okay, it is going to get disrupted for sure. Now coming on to, after the radiological things, now coming on to the next part, and that is called as management. Okay, that is called as what? That is called as management part. Okay, and after management, I'll take you through some of the complications of the supracondylar fracture. Okay, I'll take you through the complications of the supracondylar. One second. Yeah, then we will discuss about the complications of the supracondylar fracture. Okay, so let's discuss about the management. So what you do, so you use a slab, okay, that is called as above elbow slab. Okay, you use a slab that is called as above elbow slab will be used, okay, after the closed reduction. So you do closed reduction, and after doing the closed reduction you will use a above elbow slab, okay. And then once it is, once the swelling is subsided, then of course this slab will be converted into a cast, okay. It will be converted into a cast, okay, if it is a posteromedial displacement. And for example, if it is a posterolateral displacement, then again you have to keep the patient's hand in supination. Then you have to keep the patient's hand in what? In supination. Okay. So this is how it is important. Okay. And after that, please understand closed reduction and percutaneous spinning. Understand this closed reduction. Okay. I'll write this closed reduction and percutaneous spinning. Closed reduction and percutaneous spinning. So it is done in, of course, type 2 and type 3 type of fractures. Then in flexion type also you are going to do the closed reduction, and the percutaneous spinning is something which can be done. Okay, coming on to the complications now. Last topic of discussion for the supracondylar fracture, discussing about the different complications. Okay, discussing about the complications. So you have got the early complications. Okay, so early complications, if I talk about, then you have got the one is the neurovascular injury. So neurovascular injury is the early one. So neuro, of course, we have already discussed, so there is no point of discussing. But now we will discuss about the vascular. So the most common vessel which is gone is called as brachial artery. Okay, the most common vessel which is gone is called as brachial artery. It is the most serious complications that can cause the ischemic hand, that can cause the pulseless hand. Okay, that can cause the pulseless hand. Next is going to be early complication is going to be what? That's going to be compartment syndrome. Okay, compartment syndrome. Now everything about compartment syndrome has been discussed yesterday only, so just refer to yesterday's video to understand about the compartment syndrome. And it can even progress to Waxman ischemic contracture. Now Waxman ischemic contracture is today's topic, so of course we will discuss Waxman ischemic contracture after finishing this class, I mean after finishing this topic, Waxman ischemic contracture. So please understand these three are the important things which can occur. So these are the early complications. Coming on to the post-treatment complications, early complications, but post-treatment complications. So in post-treatment complications, it is very necessary to acknowledge the malunion. Okay, the elbow stiffness. Okay, the malunion can be there, the elbow stiffness can be there, and one more important thing is malunion, elbow stiffness is going to be there, and of course the infections can be there on the pin tract. So okay, so infections can be there on the pin tract. Coming on to the late complications, now. So there can be, in late complications, there can be cubitus varus. Okay, there can be what? There can be cubitus varus. This is also called as gun stock deformity. Okay, cubitus varus, which is also called as gun stock deformity. Okay, so what do you mean by cubitus varus? So for example, this is your elbow. For example, this is your elbow. Okay, so the bone which is distal to your elbow, this bone is going to turn medially. Okay, is going to turn medially. So varus means what? Varus word wherever comes. Okay, so let me just teach you this concept. Varus word wherever it is going to come, remember the distal bone to the joint. Okay, the distal bone to the joint will move medially. Distal bone to the joint will move medially in the varus deformity. And if if it comes to valgus one, then distal bone to the joint will move laterally. Okay, so here we have varus deformity. Why? Because it is a supracondylar fracture. So can you see which word is coming? R is coming first, L is coming a little late. That is why it is a varus deformity and not a valgus deformity. Okay, why does it occur? It occurs because of the, yes, it occurs because of the malunion. Okay, malunion. It is the most common late complication. It is the most common late complication which is going to occur. Okay, which is going to occur. Now, after that, Waxman ischemic contracture, of course, we will discuss ahead. Okay, but still, I'll write it here. VIC, Waxman ischemic contracture. Then you have got myositis ossificans. Okay, myositis ossificans. So, what do you mean by myositis ossificans? So, please understand this is myositis. Of course, myositis means inflammation of the muscle. So, inflammation of muscle. Okay, which is going to be there, and of course the bone is going to start forming there. Okay, bone formation is also going to occur over here, heterotropic bone formation in the muscle. So why does it occur? So it occurs because of repeated massage. Okay, repeated massage. Okay, so dadis, nanis, they are fond of doing the massage everywhere, but this is not good because this can even cause myositis ossificans. And yes, sometimes we have seen that the growth disturbances can also occur. Okay, the growth disturbances can also occur in these cases. Okay. Yes, so this is all about the very first topic of discussion of this class. This is the supracondylar fracture of humerus, which is also, I mean, which is asked as a long question, long answer question. It's a very potential question which can come in your examination. Okay, so this is about the supracondylar fracture of humerus, supracondylar fracture of the humerus. Okay, so this is again very important thing. Okay, but yeah, so so yeah, so closed reduction, percutaneous spinning, we have discussed this. Now let me just tell you, like, if we just talk about one, two things over here, extra important things, I'll make two boxes over here so that you can just remember these two boxes and the things will fall in place. So one box is that what is it an emergency or not? So supracondylar fracture, is it an emergency or not? See, understand that it is not an emergency condition. Okay, generally it is not an emergency condition. Okay, not an emergency condition, but when you will call it as an emergency condition, it is called as an emergency condition when you have pulselessness. Okay, if there is pulselessness, if there is no pulse in it, so it's going to be what? It is going to be an urgent condition, an emergency condition. Then if there are some sensory nerve deficits, okay, अगर सेंसरी नर्व का कुछ इशू आपको लग रहा है, sensory nerves deficits is going to be there. Okay, then if there it is showing the signs of complications, okay, like the compartment syndrome. Okay, if any signs of complications like compartment syndrome is being shown, then it is going to be what? It is going to be an emergency condition. It is called as an emergency condition. Okay, so this is something which you have to understand. And the next box, I'm just trying to teach you a little bit what is the technique, of fixation of the supracondylar fracture. So we have got two techniques. One is something which is called as two lateral pin technique, two lateral pin technique, or it can be fixed by the three lateral pin technique. Okay, so two lateral pin technique, three lateral pin technique, and there is something which is called as crossed pins. Okay, it is also called as something which is called as crossed pins. So this is also important. Okay, so just remember this, that these are the different techniques which we use. Okay, so two lateral pin technique is used generally up till type 2 fractures. Three lateral pin is generally type 3 and type 4 fractures. Okay, and crossed pins is biomechanically most strongest one. It is biomechanically the most strongest one. Okay, it is the biomechanically most strongest one. Okay, so this is how you have to understand. Complications, of course, I have discussed with you. Um, yes, okay, correct. So after that, so this is about your supracondylar fracture of humerus. Okay, हाँ जी. So we are done with supracondylar fracture humerus. Okay. So now we will discuss about the Colles fracture and then we will discuss about the Smith fracture. Okay. So let's discuss about the fractures now one by one. Colles fracture and the Smith's fracture. So before I go on to the Colles fracture and the Smith's fracture, let us discuss a case. See here. A 65-year-old woman slips in the bathroom. A typical history when they want to give you about the Colles fracture. Slips in the washroom. ये तो मतलब बहुत ही common history है जो कि दी जाती है about the Colles fracture. So slips in the bathroom and falls on the outstretched hand. She presents with pain and swelling over the wrist, and there is a dinner fork deformity which is there in Colles. Now, you know what, I have seen a lot of students doing this common mistake. They see the dinner fork deformity and then they get confused between the Colles and Smith. Please remember that in alphabet C and D letters come together. So C for Colles fracture and D for dinner fork deformity. So dinner fork is like this. Okay, dinner fork I'll show you. Whereas in Smith's fracture, see, okay, one more thing, it is going to have fall on the outstretched hand. It is also going to have what? It is going to have foosh injury. Okay. Smith's fracture. Smith's fracture is a flexed wrist. Okay. When they are going to fall on a flexed wrist like this. Okay, following a road traffic accident, and again there is a deformity which is opposite to that which is seen in Colles fracture, which is actually called as garden spade deformity. Garden spade deformity. So garden spade deformity is something which is seen in which fracture? Garden spade deformity is something that is seen in the Smith's fracture. It is seen in which fracture? It is seen in the Smith's fracture. So this is the garden spade deformity that is seen in the Smith's fracture. So of course, Colles and Smith's fracture, both of them are really very important. Okay. Just one important thing before we go ahead. I think everything I've shown you from this, yeah, ये हमने सब पढ़ लिया है. Coming on to the Colles and the Smith's fracture now. Just one second. Let me just see. Yeah. So can you see this is called as a dinner fork deformity? Can you see this is a dinner fork which is there upside? I mean, the yeah. Uh, मतलब as if हमने खाना वाना खा लिया तो हम लोग ऐसे उसको टेढ़ा करके रख देते हैं, है ना? So this is the dinner fork deformity which you can of course see over here. Dinner fork deformity which you can see over here. Okay, dinner fork deformity, and something which you can see over here as well. Okay, something which you can see over here as well. This is the dinner fork deformity, and can you see this is the fall on outstretched hand, and here it is the flexion which is there. It is the flexion which is there. Okay, where the fragment which is जो टूटा fragment है, the fragment which is fractured is either going onto the outer side, onto the dorsal side, then it is called as Colles fracture. C and D again coming closer. And if it is going to show ventral dislocation anteriorly, if it is going, then it is nothing else but the Smith's fracture. ठीक है जी, फिर उसको आप क्या बोलेंगे? Smith's fracture बोलेंगे. So without wasting even a single minute, let's quickly start with the Colles fracture. सबसे पहले हम लोग पढ़ेंगे अबाउट द कोलीज फ्रैक्चर. Okay, so we will be discussing the Colles fracture. So I hope the things are making sense, right? So generally I don't watch anonymous says trauma. Yes, but we are discussing the trauma itself. Okay, Chalo. Quickly, let's understand about the, yes, let's understand about the Colles fracture now. Just give me 1 minute. All right, bache, Colles fracture. So you know very well till now you have understand the what is the mechanism of injury. That is the Fush is the mechanism of injury. Okay, Fush is the mechanism of injury. Okay, so coming on to the Colles fracture. So what we will discuss in the Colles fracture, one is going to be the characteristics of the fracture. Just 1 second. So firstly, we will discuss about the characteristics of the fracture, the definition and everything we will discuss. Okay, characteristics of the Colles fracture. After characteristics, we will discuss about the related injuries. After the related injuries, we will discuss about the clinical features. Then we will come on to the diagnosis. And after diagnosis, we will discuss about the treatment part. And after treatment part, we will discuss about the complications. Okay, we will discuss about the complications of Colles fracture. So characteristics, related injuries, clinical features, diagnosis, treatment, and the complications itself. Okay, so coming on to the characteristics. Okay, just 1 second. Oh, yeah. So characteristics, first of all, the very first heading, that is characteristics. And what is the first characteristic? That's actually a general note which you should know, that this Colles fracture was named after the scientist Abraham Colles. Okay, so it was named after a scientist whose name is Abraham Colles. Okay, Abraham Colles. Okay, now, so it commonly occurs in the postmenopausal female. Okay, it commonly occurs in the postmenopausal female. Okay, and the mechanism of injury, postmenopausal female, and the mechanism of injury. Let me just write down postmenopausal female. Just 1 second. It is seen in the postmenopausal female, and the mechanism of injury is again the foosh, the fallen outstretched hand. It presents in the individuals who are more than 40 years of age, and yes, there is a history of fall on outstretched hand, which is very common in the Colles fracture. Okay, so what you have to understand in this is that what is the location. So it is at the corticocancellous junction. Okay, so what is the location? Location, it has the corticocancellous junction. Okay, corticocancellous junction. Okay, corticocancellous junction of which bone? Of the distal radius, corticocancellous junction. Okay, and it is the which type of fracture? It is the transverse fracture. It is the transverse fracture of distal radius. It is the transverse fracture of distal radius, which is associated with, now comes the proper definition, which is associated with distal subluxation. Okay, or you should say the dorsal subluxation of the distal fragment. Dorsal subluxation of distal fragment. Okay, dorsal subluxation of the distal fragment. Okay, so this is something which is called as Colles fracture. So this is something which is called as Colles fracture, right? So after the location, now we will discuss about the different types of, okay, different type of. So please understand the important part which is there before we discuss about the different types of the fracture is that there is a lateral tilt, there is a lateral displacement, okay, of the main, I should say, the parent bone. Okay, so dorsal subluxation of the distal fragment, plus there is a lateral tilt which is going to come of the parent bone. Okay, there is a lateral tilt which is going to come in the parent bone itself, and yes, there is going to be supination also. There is going to be what? There is going to be supination also of the hand. Okay, so before discussing the types, let's understand about the related injuries. Okay, let's understand about the related injuries in this case of what? In case of the Colles fracture. So one is going to be the ulnar styloid fracture. There can be ulnar styloid fracture which is going to be there. Of course, the distal radius is going to be fractured, but ulnar styloid fracture, this is the common associated injury. The other injuries are the ligament damages, okay, and the cartilage damages as well. So what are the ligament and cartilage which can be damaged? There can be ulnar collateral ligament, okay, ulnar collateral ligament, that is shown to have the damage, ulnar collateral ligament, and then there is something which is called as triangular cartilage of ulna. There is something which is called as triangular cartilage of ulna. Both of them are damaged. So one is the ulnar collateral ligament and the other one is the triangular cartilage of ulna. So ulnar collateral ligament and triangular cartilage of ulna. So can you see C? Okay, ulnar collateral ligament and the triangular cartilage of ulna. And yes, there can be damage to the intraosseous membrane. Okay, intraosseous membrane between the radio ulnar joint can be damaged, and that's why it leads to radio ulnar dislocation, or yeah, it can lead to, that means it can lead to radio ulnar dislocation as well, radio ulnar dislocation as well. Okay, coming on to the next part, that is what are the different clinical features associated with this injury. So please understand that first of all, the clinical feature, the history will show what? Fall on outstretched hand. It will show history of the fall on outstretched hand. Then there is going to be what? Then there is going to be a dinner fork deformity. Okay, there is going to be a dinner fork deformity, and dinner fork deformity is a classical sign. Okay, dinner fork deformity is a classical sign which is going to be there in case of Colles fracture. Okay, this dinner fork deformity is also called as bayonet's fracture. Okay, it is also called as what? It is also called as bayonet's deformity. Okay, not fracture but bayonet's deformity. Okay, bayonet's deformity. Why? Because of radial and dorsal displacement of the wrist. Okay, because there is a, what is dinner fork deformity? It is the dorsal and radial displacement of the wrist, dorsal or radial displacement of the wrist and the hand. Okay, and understand one more thing, that is displacement of radial styloid. There is going to be displacement of radial styloid as well. Okay, so there is displacement of radial styloid as well, and that can be palpated. Okay, that can be palpated or even seen on the examination. So there is displacement of the radial styloid as well. Okay, and then what you will see on the wrist, so wrist, of course wrist is also going to show you some of the other changes. Okay, the wrist will show you prominence on the back side. Okay, there is going to be prominence on the back side. So the wrist is going to show you the prominence on the back side, prominence on the back side, and of course a depression on the front side because there is a prominence on the back side. Okay, and of course there will be some common features of fracture as well, the pain, the swelling, the tenderness. Okay, so common fracture symptoms are also going to be there. Okay, so coming on to the next part, how will you make the diagnosis? Okay, coming on to the next part, how will you make the diagnosis of this? So please understand, the primarily diagnosis is going to be clinical, and yes, the radiological examination is again very 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 necessary to confirm the diagnosis of Colles fracture. Now, clinically, you will have the dinner fork deformity, of course. Okay, clinically, you will have the dinner fork deformity, and radiologically on x-ray it's going to be there. Okay, so just understand that the dorsal tilt is the main feature which is seen on the एक्सरे. ठीक है, एक्सरे में जो मेन फीचर दिखता है उसको हम लोग क्या बोलते हैं, उसको हम लोग बोलते हैं डॉर्सल टिल्ट. देयर इज अ डॉर्सल टिल्ट व्हिच इज गोइंग टू बी देयर. So coming on to the last part, that is called as treatment. Okay, coming on to the last part, that is called as the treatment of Colles fracture. Okay, so that depends if it is an undisplaced fracture or it is a displaced fracture. So if it's an undisplaced fracture, we have to do which treatment? We have to do a conservative treatment in that case. And what is going to be the conservative treatment? Yes, what is going to be the conservative treatment? Like the immobilization. So forearm is immobilized. Okay, so there is going to be immobilization of the forearm, which is done by applying an elbow cast, for a period of 4 to 6 weeks. Okay, for a period of 4 to 6 weeks, this is the undisplaced fracture. Okay, and after that you have got a displaced fracture as well. So if it's a displaced fracture, which is actually more commonly seen, okay, so this is something which is more commonly seen, so we have to do close reduction. And in close reduction, we also have to understand that we have to do it under anesthesia, because otherwise it's extremely painful. So we have to do closed reduction, and closed reduction has also been done in the under the anesthesia. Okay, it has to be done under the anesthesia. Okay, so this is the another thing which you have to understand. So closed reduction, and that's to have to be done under the anesthesia. Okay, now again the follow-up x-rays have to be done, okay, for first month. Okay, so follow-up x-rays has to be done in the first month. Okay, if for example there is a severe fracture, okay, so next important part is severe comminuted fracture, then what you will do. So if there is a severe comminution fracture which is going to be there, comminuted fracture, then in these cases we have to do the k wire fixation. Okay, we have to do what? We have to do the k wire fixation in that case, which is done. Okay, or you can use the compression plates. Okay, locking compression plates. Okay, these kind of plates can be used. Locking compression plates can be used. Okay, so and just leave some gap over here. I'll tell you what is the sequence of correction. Okay, okay, I'll teach you about the sequence of correction in the Colles, like the tilt, the displacement, how it is done. I'll teach you in the end of the session. Okay, so now we will discuss about the complications. So first of all, the complication is going to be stiffness. Stiffness is the most important complication which you have to understand. Okay, and that's why we always say patients to undergo physiotherapy. Okay, stiffness is one. Next is malunion, that is most commonly seen. Okay, malunion, which is very much seen, because this area is just like that only. Then of course shortening of radius. Okay, shortening of radius is something which has also been seen. Why shortening of radius? Because you know, it results from the subluxation. Okay, it results from the subluxation of inferior radio ulnar joint. Okay, subluxation of radio ulnar joint, making the ulnar head, okay, making the ulnar head visible prominently, making the head of the ulna visible very much prominently. It will be visible very much prominently. So shortening of radius is another important thing which can be seen, okay, in the Colles fracture. Now after that, remember there is something which is called as Drake's resection, which is done for the treatment of shortening of radius, that is called as Drake's resection. Okay, Drake's resection is something that is done in the to get rid of this. Then some late complications like carpal tunnel syndrome. Okay, carpal tunnel syndrome can occur. Okay, in this case, okay, carpal tunnel syndrome is also something which is associated with this. And then reflex sympathetic dystrophy, that is seen. So what is reflex sympathetic dystrophy? It's a dystrophy which is going to occur because of vasomotor instability. Because of vasomotor instability, it is also called as Sudex dystrophy. It is also called as Sudex dystrophy. Why does it occur? It occurs because of the neurovascular damage. It occurs because of the neurovascular damage, like the pain, redness, swelling, all these things can occur. Sudex dystrophy. Okay, so there can be what? There can be pain which is going to occur, there is going to be redness which is going to occur, there is going to be what? There is going to be the osteodystrophy which can occur in this case. Okay, after that, the next thing which can occur is the tendon rupture. Okay, it is the tendon rupture. And which tendon is ruptured? So tendon rupture is generally extensor pollicis longus. Okay, extensor pollicis longus. Extensor pollicis longus is the tendon which is ruptured. Extensor pollicis longus is the just one second. Tell the content. Yeah. So extensor pollicis longus is something which is ruptured. Okay, which is ruptured. Okay. So this is again which is there. Okay. And in order to correct it, we generally use the extensor indicis tendon. Okay. Extensor indicis tendon is something that we generally use to correct the extensor pollicis longus tendon. Okay. Extensor pollicis longus tendon. So now, so yeah, so after that we have to understand the next part, the the just one second, just one second. Yeah, so come on to this table. So just remember, in order to correct your um, Colles fracture, we have to remember DILS. Okay, and DILS, D for dorsal, okay, ST, I for impaction, and then you have got lateral, ST, and radial. Okay, so um, so impaction. Just understand this now. This just give me one second, guys. I'm having some issues in my app. Are you guys able to watch this properly? Yes. Are you guys able to watch this properly? I think it's fine. Okay, 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 okay. So what you have to do, leave this DILS also. So what you have to do, first of all, we have to apply the traction. We have to apply the counter traction. So why this counter traction and traction is applied to, to get rid of, to get rid of impaction. Sometimes what happens is that the bone fragments are impacted within one another. So to get rid of impaction, we apply the traction as well as the counter traction. And then we do correction of dorsal tilt. Okay, we do the correction of dorsal tilt. So dorsal tilt is something that is corrected. And then we do the correction of radial tilt. Okay, then we do the correction of what? Then we do the correction of radial tilt. So this is doctor. We have to understand D for dorsal tilt correction and the R for radial tilt correction. Okay, so this was all about the Colles fracture. Okay, so now what we will do, we will take a small chotu sa break of say 10 minutes, and then we will meet at 11:20. Okay, so we will meet at 11:20. Okay, and then we will discuss the next fracture, that is the Smith's fracture. Okay, chali, we'll meet at 11:20. Break. All right, Vijay. So now this is the perfect time to start with the second half of today's class, and now we will be discussing about the Smith's fracture. Yeah. So now we will discuss about the Smith's fracture. So what do you mean by Smith's fracture? So Smith's fracture is also called as reverse Colles fracture. Okay. So Smith's fracture is also called as reverse Colles fracture. So whatever you read in the Colles fracture, now you reverse it, it becomes the Smith's fracture. Okay. So it is most commonly seen in adults and elderly people. Okay, so let me just write down what is the age group in which it is seen. So it is seen in the adult patients, in the adult age group, in the elderly age group. Okay, and very important thing which you have to understand is that why it is called as reverse Colles. It is also it is called as reverse Colles because in this fracture the distal fragment, okay, the distal fragment goes anteriorly. Okay, in this fracture the distal fragment is going to go anteriorly. Okay, coming on to what is the etiopathogenesis, okay, or you can say the mechanism of injury. So it is also known as, we have seen, it is also called as the age group, we have seen. Let us understand now about the mechanism of injury. Okay, one second. So the age group you have discussed, also known as you have discussed. Now we will discuss about the mechanism of injury. So what is the mechanism of injury? The mechanism of injury is going to be falling on the flexed wrist. Okay, falling on the flexed wrist. Okay, supinated forearm. Okay, supinated forearm, flexed wrist. Okay, or you can say the direct trauma when the hand is in flexion or supinated forearm, or the arm is supinated or the hand is in flexion, then that is called as what? That is called as your Smith's fracture. Coming on to the next part, what are the clinical features? Okay, what are the clinical feature in Smith's fracture? So the clinical features is, of course, the patient has signs of inflammation. Yes, that's very true that this is the fracture where there will be signs of inflammation. There will be signs of fracture. There will be signs of, or you can say, visible deformity. Okay, and what this deformity is called, this we have already discussed, that this deformity is called as garden spade deformity. Garden spade deformity. And what are the signs of fracture? So signs of fracture, of course, the pain is going to be there, tenderness is going to be there, swelling is going to be there. Okay, then uh, decreased movements are going to be there on the wrist joint. Okay, decreased movement will be there on the wrist joint. Now please understand this again, very important thing, that your diagnosis. Okay, so when you want to do make the diagnosis, so please understand it is again a cortico cancellous transverse fracture at the distal end of radius, where the distal fragment goes anteriorly. This is something that will be seen on X-ray. This is something that will be seen on your clinical examination as well. Clinical examination as well. After diagnosis, let's understand now about the treatment modalities for Smith's fracture. Okay, now we will discuss about the treatment modalities for Smith's fracture. So please understand the treatment in the Smith's fracture mostly is the closed reduction. Okay, so mostly what you do closed reduction. Mostly what you do the immobilization. Okay, so first of all, of course, the closed reduction, then immobilization, then cast is something that is applied. Okay, So closed reduction, immobilization, cast is applied with supination of forearm and extension in the wrist. Okay, cast is applied with the supination in forearm. So supination in forearm and wrist extension. Okay, extension in the wrist and supination in the forearm. This is something which you have to understand. And for example, if the fracture is unstable, okay, if the fracture is unstable, then in unstable fractures, what you are supposed to do, you are supposed to apply the K wires, open reduction, internal fixation. K wire, okay, with the ORIF, that is open reduction, internal fixation. Open reduction, internal fixation is something which you have to do. Okay, open reduction, internal fixation is something that you have to do. And complications, so the complications are very much similar. Okay, complications are very much similar to that of Colles fracture. Okay, so complications are very much similar to that of Colles fracture. So whatever is important for Colles fracture, similarly will be important for your Smith's fracture as well. So we have discussed the Colles fracture. We have discussed the Smith's fracture also. Let's quickly, I think we can finish up with the Barton's and the Schoffer's fracture also. Let me just see if I've mentioned in the list or not. Barton's fracture and the Schoffer's fracture also. Okay. So we have not mentioned it here. I'll mention it here. Barton's fracture and the Schoffer's fracture. These both are actually important for the MCQ purpose only. So I'll just tell you what is Barton's fracture and what is Schoffer's fracture. Okay. So Barton's fracture as well as Schoffer's fracture. So what is Barton's? Now, okay, I'll write it over here only. Barton's fracture. If you want to know, just remember Dr. Barton's. That's the mnemonic. Dr. Barton's. Okay. So Dr. Barton's. Doctor means what? DR. DR for distal radius fracture. Distal radius fracture. This is doctor. And Barton's. Barton's is A and R. That means intra articular fracture. So distal radius fracture, intra-articular fracture of the distal end of the radius. Okay. And Barton's, please understand this R is the last word and this is the S is the last word. That means there is a radioscaphoid dislocation. Radioscaphoid dislocation that is going to occur. This is really important if you are appearing for an MCQ exam. Dr. Barton's distal radius fracture, intra-articular fracture, radioscaphoid dislocation. Radioscaphoid dislocation is going to be there. This is called as Barton's fracture, Barton's fracture, Barton's fracture. Really very important. Okay, very important. And similarly, there is Dr. Schoffer's fracture. Again, this Schoffer's fracture is also Schoffer's fracture क्या होता है? That's also a distal radius fracture. Okay, that's also an intra-articular fracture, but here you will see the avulsion. Please understand there is an avulsion of the radial styloid. Okay, here you will have the avulsion of radial styloid. So because there is avulsion of radial styloid, this is a this is what this is a Schoffer's fracture. And please remember this Schoffer fracture has its name from B. It's a B also, that is called as backfire fracture. So backfire fracture, Schoffer fractures, Barton's fracture. This is important for your MCQ purpose as well. Okay, so this is it for these distal radius fractures. Coming on to the Monteggia fracture, coming on to the Bennett's fracture now. Okay, so now we will discuss about the Bennett's fracture and the Monteggia fracture. Okay, yeah. So So just give me 1 minute. Mantesia fracture as well as Bennett's fracture I'll discuss with you. Just give me 1 minute. Yeah. So coming on to the Bennett's fracture, which is also called as Bennett and Rolando fracture. Bennett and Rolando fracture. Hanji. So what is Bennett and Rolando fracture? See, understand this is the base of. So first of all, let me just tell you like this. Ki what is Bennett fracture and Rolando fracture? So Bennett fracture is the बटन बेनेट को ऐसे याद करो बटन ठीक है बटन क्या होता है टिच बटन होता है ना जैसे एक बटन ये रहा दूसरा बटन ये रहा दोनों बटन टिच बटन दोनों ऐसे आपस में क्या हो जाते हैं ये दोनों के दोनों बटन आपस में क्या हो जाएंगे दोनों के दोनों बटन आपस में टिच करके बंद होंगे ठीक है राइट सो व्हाट यू हैव टू अंडरस्टैंड टिच बटन विच बटन टिच बटन टी टी फॉर ट्रेपिजॉइड so it is a trapezio okay trapezio okay trapezio first metacarpal joint trapezio first metacarpal joint okay trapezio first metacarpal joint and there is one button two button दोनों के बीच में क्या है inter articular okay inter articular so Bennett's fracture is an inter articular fracture of base of first metacarpal of base of first metacarpal that is going to extend into trapezio first metacarpal joint. It is going to extend into trapezio first metacarpal joint. Okay, so this is called as nothing else but Bennett's fracture. But what is Rolando fracture then? Rolando fracture is a more than two parts. Okay, so this is going to Bennett's fracture is intra-articular two-part fracture. Okay, two parts. So for example, this is first metacarpal, there will be a crack, and that crack will divide the first metacarpal into two halves. But Rolando fracture is more than two part. Okay, more than two part. That's it. बाकी सब same है. More than two part, बाकी सब same है. और इसी की वजह से more than two part होने की वजह से either there will be a T-shaped or it will be a V-shaped or it will be a Y-shaped fracture. Either it will be a T-shaped fracture, V-shaped fracture, Y-shaped fracture that is going to be there. That is called as Rolando fracture. Okay, that is called as what? It is called as Rolando fracture. Okay, so intra-articular if it is there, then only you will call it as Bennett. Intra-articular if it is there, then only you will call it as Rolando fracture. Otherwise, every fracture is going to be an extra-articular fracture and that's it. ठीक है, तो ये आप लोगों को समझना बहुत जरूरी है. इन दोनों के लिए व्हाट इज द मैकेनिज्म ऑफ इंजरी ठीक है व्हाट इज द mechanism of injury so the mechanism of injury in both these cases is going to be axial force applied to thumb inflection axial force which is applied to thumb in flexion that's it axial force which is applied to thumb in flexion that's it okay so what is going to be the clinical feature so very simple nothing to कुछ बहुत ज्यादा इसमें है नहीं क्लिनिकल फीचर क्या है एक तो हमेशा से क्या होते हैं जो भी फ्रैक्चर के सिम्टम्स होते हैं जैसे कि पेन स्वेलिंग एकाइमोसिस टेंडरनेस रेंज ऑफ मोशन इज कॉम्प्रोमाइज्ड ठीक है ओके so again I'm writing the same things there will be pain there will be swelling there will be tenderness there will be what there will be decrease in movement okay and one more important part that is Where is the tenderness? In CMC joint. Carpometacarpal joint will show you the will show you what? Will show you the CMC joint tenderness that's going to be there. Okay, tenderness is going to be there. Okay, so what are the what is the how will you diagnose the condition? So in order to diagnose the condition, what we do first of all is the X-ray. Okay, so X-ray is something which we do, and what is the view which we take for looking at these X-rays? That is called as Roberts view. Okay, this is the Roberts view. Okay, so that's it. This is something which you have to understand. This is the Roberts view. Okay, and तो आपको दिखेगा क्या, वो मैंने आपको बता दिया है ऑलरेडी. ठीक है. नाउ बेनेट्स फ्रैक्चर एंड रोलांडो फ्रैक्चर में एक कुछ तो हम क्राइटेरिया यूज करते हैं. वो क्या है? फॉर एग्जांपल, इफ देयर इज लेस देन 30 डिग्री एंगुलेशन. ठीक है, if less than 30 degree angulation is there between the fracture segment and the parent bone, then this is an extra articular fracture. This is mostly an extra articular fracture. Whereas if there is less than 1 mm step off, okay, step off means that the resulting bone is stepping off from the parent bone, that is less than 1 mm step off is there, then this is called as Bennett's fracture. Okay, Bennett's fracture. And just remember what is Rolando fracture. So Rolando fracture means that there is comminution dictates. Okay, so there is going to be what? There is going to be comminution that will be seen in the Rolando fracture. That will be seen in the Rolando fracture. Okay, so how will you do the management of these cases? Okay, what will you do in the management of these fractures? So for the management purpose, just understand we have got the conservative management, and then we will proceed on to the surgical management. So conservative management is there, then there is surgical management. What do we do in conservative management? In conservative management, we do closed reduction by using a thumb spica. Okay, thumb spica casting. So close reduction, thumb spica बोलते हैं उसको, वही कास्ट होता है एक तरीके का. ठीक है, सो क्लोज रिडक्शन करोगे, थंब स्पाइका कास्टिंग आप लोग करोगे. ठीक है, तो ये चीज आप लोग को समझ में आनी चाहिए, वेरी वेरी इंपॉर्टेंट. सर्जिकल हम लोग कब करते हैं? सर्जिकल में करते क्या है? देयर इज अ क्लोज रिडक्शन प्लस के वायर फिक्सेशन. सो क्लोज रिडक्शन करते हो, के वायर फिक्सेशन करते हो, ये दोनों चीजें बहुत इंपॉर्टेंट है. क्लोज रिडक्शन एंड के वायर फिक्सेशन. एंड जस्ट रिमेंबर वेरी वेरी इंपॉर्टेंट थिंग, क्या चीज? देखो, अगर आप reduction, okay, so you do it when there is inability to maintain reduction, less than 30 degrees with thumb spica. Okay, right? And for example, if the small fragments can't be fixed with screw fixation, there might also be the need of doing the open reduction and internal fixation when the displacement is more than 1 mm. If the displacement is more than 1 mm, okay, plus there are large fragments. Okay, if there are large fragments plus displacement is more than 1 mm. Okay, right? Of course, we can also go for you know, distraction and external fixation, distraction plus internal fixation as well. If you know the fragments, if the comminuted fragments are so small that they can't be even fixed with ORIF. Okay, comminuted fragments, comminuted fragments, even small for open reduction and internal fixation. Now what can be, last part, what can be the different complications? So in complications, of course, there will be stiffness, there will be instability, there will be arthritis, post-traumatic arthritis, and there is going to be malunion. Okay, arthritis and post-traumatic malunion, it is going to be there. Okay, so all these things are going to be there if it's a Bennett and a Rolando fracture. Bennett fracture and Rolando fracture. Okay, and this is the end of the Bennett fracture and Rolando fracture. Now we will discuss about the next topic, and that is called as Montegia's fracture. Okay, now we will discuss about the next fracture, that is called as Montegia's fracture. Okay, now this Montegia's fracture is always, I mean, although some people read it like that, some people don't, but I always suggest to read Montegia's fracture. Okay, थोड़ा सा spelling गलत हो गया Montegia का. Okay, I'll correct it. Montegia fracture. I always suggest to read it with the difference between the Montegia fracture as well as the Giliazzi's fracture. Okay, Montegia fracture as well as Giliazzi's fracture. Okay, why? Because Giliazzi's fracture is something which is also called as reverse Montegia's fracture. Okay, it is also called as which fracture? It is also called as reverse Montegia's fracture. It is also called as Piedmont's fracture. Okay, it is also called as what? It is also called as Piedmont's fracture. Okay, so reverse Montegia fracture, Piedmont's fracture, Giliazzi fracture, all and the same thing. So I just always teach students to remember these two words whenever it comes to Montegia and whenever it comes to Giliazzi. Okay. So whenever it comes to Giliazzi, just remember 17, and whenever it comes to Montegia, just remember 11. Now, what is important in this 11? Remember, Montegia fracture is the fracture of proximal one third of ulnar shaft. Okay, proximal one third of ulnar shaft. So this is ulnar, this is radius. So proximal one third of the shaft of ulna has to get fractured of the ulnar shaft with dislocation of the radial head, with dislocation of the head of the radius, with the head of radius being dislocated. Okay, the head of radius being dislocated. Okay, so this is how you can remember radius has dislocation plus proximal one third of ulnar shaft has to show fracture. Whereas when it comes to Giliazzi's fracture, it is the fracture of the shaft of the radius at the junction of middle and distal one third hair, middle and the distal one third. So sorry, proximal, proximal one third of the ulnar shaft and head of radius dislocation. Yeah, this is done. Now coming on to what? Now coming on to the middle and distal one third hair, something like this hair. Okay, and this is the fracture of the shaft of the radius like this. Okay, so this is the fracture of radius shaft at the junction of middle and distal, at the junction of middle and distal radius, middle and distal radius. Okay, and what is going to be there? Distal radio ulnar joint dislocation, distal radio ulnar joint dislocation is also going to be there. Distal radio ulnar joint dislocation is also going to be there. So this is in short what is Montegia fracture and what is Giliazzi's fracture. Okay, what is Montegia fracture and what is Giliazzi fracture. Okay, so I know, see, the Montegia fracture and the Giliazzi's fracture, of course, they are very important. So let's understand one by one what is Montegia fracture and what is Giliazzi fracture. Um, yeah. So, but for MCQ purpose, this is more than sufficient. So whatever I have told you regarding Montage and Giliazzi, this is something which is more than sufficient for your MCQ purpose. Now, in Montegia fracture, because Giliazzi is not asked, but yes, Montegia is something that has been asked several times. So Montegia is something that is really important. So please remember, so there is going to be a Bardo classification in Montegia. There's going to be a Bardo classification in Montegia. So let me just write down Bardo classification. Okay. So there is a Bardo classification in Montegia. What do you mean by this Bardo classification? So remember, you have got 1, 2, and 3. So 1 is anterior fracture dislocation. So whenever there is fracture, so the the dislocation is going to be anterior. So one is always the first letter of the alphabet. This is A, and this is called as anterior fracture dislocation. Anterior fracture dislocation. Then what is 2? 2 is going to be posterior fracture dislocation. Okay, what is 2? 2 is posterior fracture dislocation. Okay, then what is third? So third is going to be ulnar metaphysis fracture. Okay, ulnar metaphysis fracture with lateral dislocation. With lateral dislocation. Okay, and what is fourth? So fourth is actually 1 plus if it is having radius fracture also. Okay, radius fracture also, this is called as Bado classification. So for dil mange, more means what? The radius is also involved along with the ulna. Okay, along with the ulna. So most common overall is this, most common in children is also this, whereas if they ask you most common in adults, this is second, and second most common is also second. So second most common in children is this, whereas most common if they ask in adults is going to be the second one with the posterior dislocation. So fracture dislocation posterior is this. Okay, right? So this is something which I have tried and explained to you. Okay, right? Yeah. So there is something which is so now we will discuss about the mechanisms of injury. So this is the Bado classification, and now we will discuss about the mechanism of injury. Okay, so what is going to be the mechanism of injury? Okay, mechanism of injury. So mechanism of injury is forced pronation of forearm. Okay, यदि you are going to do forced pronation of forearm, काफी बार लड़ाई झगड़े के अंदर में forced pronation की जाती है. So forced pronation of forearm is going to be there. Okay, then axial loading. Now at your level you need not typically know what all these things are. Just remember this: axial loading of forearm, axial loading of forearm with flexed elbow. Okay, axial loading of forearm with flexed elbow. Okay, then after that you have got forced abduction of elbow, forced abduction of elbow. Okay, right, like this. Now what will be the clinical presentation? See, clinical features, very important. 3 4 things you have to keep in mind forever. There will be pain, there will be stiffness, there will be tenderness, there will be yes, one more: pain, stiffness, tenderness. Then what else? There will be deformity, there will be decrease in movement. Okay, decrease in movement. So all these things are going to be there for sure. Okay, but what we have seen in this, there is a what I should say, posterior in the wrist drop is going to be there if in this case of Montegia. Okay, wrist drop is something which has been classically seen in the cases of Montegia. Okay, wrist drop is something that has been seen in the cases of Montegia. Yes, compartment syndrome is also very common in case of Montegia fracture, compartment syndrome. And since it's a pediatric fracture, it is, I mean, not always, but yes, has been seen in pediatric age group patients also. So the anxiety, analgesia, these symptoms are also seen in Montegia fracture. Okay, right. Then age. So Montegia has classically been seen in pediatric age group only, like 4 to 10 years, but yes, it can occur in elderly patients as well. Okay, so what is the radiology now? Okay, what will you do in the if radiology is asked? So in radiology, just remember that whatever I have told you, that is going to be seen. Okay, whatever I have told you, that will be seen in Monteggia. That means there is a fracture at the proximal 1/3 of ulnar shaft. Okay, proximal 1/3 at ulnar shaft. Okay, this fracture is going to be there. And then of course, what about the radius? The radius head will be dislocated. Okay, radius head is going to be dislocated. So this of course can be this, of course you're going to see this. And so yes, other thing which you have to see is the MRI. Okay, why will you do MRI? It is just to see the congruency. Okay, MRI can be done to see the congruency of radius head and capitulum. To see the congruency of radius head as well as capitulum, we perform the MRI. Okay, we perform what? We perform the MRI. So coming on to the next part, the management part. Okay, so what you do, see, so for the typical management part, you have to see which type of fracture actually it is. Okay, so for example, if it is a, say, I mean, you have to check for the bone. So if it is a plastic deformation, or if it is a green stick fracture, or if it is a complete fracture. See, if it's a plastic deformation and if it's a green stick fracture, you have to do the closed reduction in both of cases. Okay, closed reduction. And if the closed reduction is failed, then you have to proceed to the open reduction and internal fixation. Open reduction and internal fixation. Okay, so this is really, really, really important. Okay, whereas if it's a complete fracture, okay, we have to check. Like for example, if it is less than 10 years baby and the type 1, type 2 or type 3 is there, then in these cases we can do the close reduction and casting. Okay, close reduction can be tried, and of course close reduction has shown very good effects. But for example, if it's a open fracture, more than 10 years have passed, I mean, like age is more than 10, and for example if it's a type 4 fracture, then we have to go for open reduction and internal fixation. Open reduction and internal fixation in this case, right? So this is how you are going to manage the case of Monteggia and Galeazzi. So this is the next part which we have finished for the today's class, Monteggia's fracture and the Galeazzi's fracture. So Monteggia fracture is done, Galeazzi fracture is done, Bennett's fracture is done, Rolando fracture is done. Coming on to Waxman ischemic contracture. Okay. Coming on to the Waxman ischemic contracture, let me just see if we can solve some. Yeah. So Waxman ischemic contracture. So a child treated with the tight bandaging. See, this tight bandaging is itself suggesting of what? Ischemia and the compartment syndrome. Tight bandaging is itself suggestive of ischemia because of the, because of what? Because of the compartment syndrome, right? Waxman ischemic contracture. Yeah, for a supracondylar fracture. Okay, fine. Severe forearm pain is there, followed by clawing of fingers. Clawing of fingers is there and forearm pain is there. So this is because of ischemia, and clawing of fingers is because is suggesting what? It is suggesting the contracture. So pain is because of ischemia and contracture is the clawing of fingers. So Waxman ischemic contracture, let's understand. But before that, let's just see this. So a boxer presents with the pain and the swelling of the base of the thumb. Base of the thumb, that means what? Base of the thumb means first metacarpal joint is going to be there. Okay, so first metacarpal joint is gone. So either it can be a Rolando fracture or it can be a Bennett's fracture. So either it can be a Bennett's fracture or it can be Rolando fracture. We have to do the x-ray to check the answer in that. Okay, so Bennett's fracture, see, this is only one part gone, and Rolando fracture, see, it is two parts, and this is typically which part, which shape? This is a V-shaped fracture which is there. Now what is this? So can you see, this is the ulna bone, this is the radius bone. Okay, and ulna bone is having the proximal 1/3 fracture, okay, which is there. And although radius is not very evidently dislocated, but yeah, slight dislocation is there. So radius head is also dislocated, and this is the uh, Monteggia fracture. This is what? This is the Monteggia's fracture is there. Okay, then Barton's fracture is also done. This is the intra-articular fracture. This is the um Dr. Barton. So distal radius, intra-articular fracture, radio, the radius and the scaphoid are going to show dislocation. Not very clear in this X-ray, but mm, yeah, not very clear in this X-ray, so we should not comment it. But yeah, anyways, we have discussed this. Schoffer's also we have discussed, where the radial styloid is gone. Okay, radial styloid is something which is gone. Okay, so this is something which we have seen. Other pictures are yet to be seen. Okay, okay. So coming on to the Waxman ischemic contracture now. Okay, Waxman ischemic contracture. So next topic discussion, Waxman ischemic contracture. Okay, so just give me 1 minute. Okay, one important point to be written here, complications of Montagia. So sorry, I missed it. So complications of Montagia is, of course, three, four things only. The neurological injuries, especially the radial nerve, anterior introitious nerve, posterior introitious nerve. Okay, myositis ossificans, compartment syndrome. Okay, and yeah, so these things are really important when it comes to the complications. Then coming on to the next part, Waxman ischemic contracture. Yeah, so Waxman ischemic contracture now. Okay, so let me introduce you to this topic. So what is the definition of Waxman ischemic contracture? The definition says that it is the condition which is characterized by ischemic necrosis of the structures, ischemic necrosis of the structures in the forearm, ischemic necrosis of the structure in the forearm, and subsequent crippling contractures associated with varying degrees of neurological deficits. Associated with varying degrees of neurological deficits. All right. So now please understand what are the different causes of this. Now we will discuss about the different causes. So causes, the very first important cause is prolonged is the compartment syndrome. Okay, of course, the different causes of compartment syndrome, you can write it over here. Like for example, the fractures are going to be there, then the tight cast is going to be there, the tight bandages is going to be there. Okay, so all these things, compartment syndrome, burns can be there, skin bite, the snake's bites can be there. Okay, then please understand, remember, supracondylar fracture humerus. Okay, so supracondylar fracture of humerus, very important, very important. It is the second most common cause. Okay, uh, right. So just remember, the second most common cause is the supracondylar fracture humerus after the compartment syndrome. Okay, then you have got some crush injuries which are going to which are going to crush even the vascular bundles, and since the vascular bundles are crushed, definitely you are going to have what, you are going to have problems. Okay, then severe contusion of forearm. Okay, severe contusion of forearm. So if forearm is gone, severe contusion of forearm is going to be there. Then chronic infections can be there, can be the cause, And in fact, one important other cause is congenital, the congenital cause itself. Okay, congenital cause itself. So what happens now? Okay, what is the pathogenesis? Let's understand about the pathogenesis. So what happens because of prolonged ischemia of muscles and nerves in the periphery, the muscles are going to undergo fibrosis. Sorry, muscles are going to undergo necrosis and fibrosis, and these both leads to what? This both leads to contracture, responsible for causing contracture. Okay, necrosis generally occurs after 6 to 8 hours of ischemia. Okay, and then what is going to happen? Contracture of the necrotic tissue. Okay, contracture of the necrotic tissue is going to occur. So this is how it is going to cause the Waxman ischemic contracture. Okay. Now in this, flexure digitorum profundus and flexure pollicis longus. Flexure digitorum profundus and flexure pollicis longus, both of them are the most common muscles. Both of them are the most common muscles. Okay, this is called as sedans ellipsoid. Okay, sedans, it's not sedans, sedans ellipsoid. Okay, right. And which is the nerve which is most commonly involved? Median nerve is the nerve which is most commonly involved. Median nerve is the nerve which is most commonly involved. Okay, in the Waxman ischemic contracture. Okay, and that is why, keeping in mind all these things, a classification was made. Okay, a classification was made again, which is called as Sedans classification. Okay, this is called as which classification? Sedans classification only, in order to classify this Waxman ischemic contracture into a mild, a moderate, or a severe contracture. A mild, moderate, and a severe contracture. So what about a mild, moderate, and severe contracture? So remember, mild means what? Deep flexor muscles. Deep flexor, like flexure digitorum profundus. Deep flexor muscles are degenerated. Okay. But the good part is that the joint is not involved. Okay. Joint is not involved in this. Okay. There will be no sensory disturbance. There will be no sensory disturbance which is going to be there. Okay. What about moderate? Yes. What about moderate? Of course, there will be flexures. So here, some deep flexures were involved. Here, all deep flexures are gone. Okay, all deep flexures are gone, and it is going to show what? It is going to show the contracture. It is also going to show the the sensory symptoms also. The sensory problems are also going to occur. Okay, what about in severe? In severe, you will have necrosis plus paralysis also. So now there will be motor symptoms also which are going to come. Okay, motor symptoms are also going to come. Okay, right? Like this, you have to understand mild, moderate, and severe. Okay, and there is one more classification, if you can remember, that is called as Zancoli's classification. There's a classification which is called as Zancoli's classification. And what happens in Zancoli's classification? One is normal intrinsic muscle type. Normal intrinsic muscle type. Then is paralytic intrinsic muscle type. Paralytic intrinsic muscle type. And the last one, the very severe one, is retracted intrinsic. Retracted intrinsic muscle type. So what is going to happen in these three? Just remember, there will be simple digital claw. Okay, there will be simple digital claw. That means the digits are going to show the what the claw, and contracture जो है वो सिर्फ और सिर्फ forearm muscle का रहता है. Okay, only the forearm contracture is going to be there, whereas paralytic intrinsic muscle type means that there will be intrinsic muscle paralysis associated with, so of course ये तो रहेगा ही रहेगा, ए तो रहेगा ही रहेगा, प्लस में क्या क्या आ जाएगा, there will be joint stiffness, there will be joint stiffness that is going to be there. There will be flexed interphalangeal joints plus metacarpophalangeal joints will show extension. Okay, there is extension in the metacarpophalangeal joint. And then retracted intrinsic means, of course, everything is going to be there, but here your distal interphalangeal joints will also go in flexion due to flexure digitorum profundus contracture, and the wrist will be in flexion. Okay, wrist will be in flexion. There's one more classification that is called as Holden's classification. Just name is more than sufficient. That is something which is called as Holden's classification. Everything belongs to Waxman ischemic contracture. Okay, so what we have to do now, coming on to the diagnostic evaluation. Okay, so now we will have to understand about the diagnostic evaluation, and the very first thing in this is called as Waxman sign. So what do you mean by this Waxman sign? So Waxman sign means inability to actively extend the fingers. Inability to actively extend the fingers. So fingers can't be extended actively. Inability to actively extend the fingers at interphalangeal joints and metacarpophalangeal joints. Okay, without flexing the wrist. So you're not allowed to flex the wrist. Okay, without flexing the wrist. Okay, then you have got something which is called as Bovier's maneuver. Bovier's maneuver. Now, what do you mean by this Bovier's maneuver? Fingers extend, actively tend to extend when the wrist is flexed. जैसे ही इनमें रिस्ट को हम फ्लेक्स करते हैं तो फिंगर्स जो है ना एक्टिवली एक्सटेंड हो जाती हैं. ओके, राइट. नाउ व्हाट एल्स? ऑफ कोर्स द रिस्ट विल बी इन फ्लेक्शन. Wrist will be in flexion. Forearm will be pronated. There will be wasting of muscles. There will be on elbow. What you will see on elbow, there will be flexion of the elbow. There will be cord-like indurations. On flexor side, paresthesia, and of course the claw hand. Paresthesia and of course what? Of course the claw hand. Okay. So what are the different differential diagnoses in this case? So when it comes to the differential diagnosis in this case, just remember there can be post-traumatic hematoma. So for example, if there is a post-traumatic hematoma, they are also going to show you these kind of features. Okay. Osteomyelitis, hematoma, and okay, from this only you can remember hemangioma of forearm muscles, hemangioma of forearm muscles, burns, Okay, so these are the different differential diagnosis. How will you treat the Waxman ischemic contracture? What will you do to treat the Waxman ischemic contracture? Of course, the very first important thing is exercise. Exercise, very important. Then turnbuckle splint, turnbuckle splint, excision of fibrous tissue. So whatever the fibrous tissue is there, you have to excise. Like for example, if it is capsule, then capsulotomy. If it is the nerve, then neurolysis. If it is the tendon, then tenolysis. So you have to do this. Okay. And then what else? You can do tendon lengthening surgeries. You can even do tendon and nerve transplant. So tendon grafting, nerve grafting. Okay. These things can be done. And some flaps are also there, like musculocutaneous flap. Okay. So first choice for these flaps are gracilis muscle. Second choice sartorius, sorry, latissimus dorsi muscle. So these flaps can be done. Okay. Then there are some operations, some plasties also, depending upon the mild, moderate, and severe part. So if it's mild, then we can do Z plasty. We can even think for max page operation. Just name for you guys is actually more than sufficient. Okay. And moderate, there is an operation. So in moderate also you can do max page operation and Gary's operation. Okay. And for severe part, you have to excise the necrotic tissue. Okay. Complete neurolysis of ulnar and median nerve. Okay. Then reconstruction. Okay. So these are the different steps which we take to treat the Waxman ischemic contracture. Okay. The Waxman ischemic contracture. So that's it. Now, yeah. So these are the different important things which we were supposed to take care, and we are done with the Waxman ischemic contracture as well. Next up, we will begin with the shoulder dislocation. Okay. And then some MCQ and everything is remaining. So we will discuss that also. Let's understand now about the anterior shoulder dislocation after a, okay. Yes. So next we will start with the anterior shoulder dislocation in a while. ठीक है. So we'll take a छोटू सा small सा break and then we will start with the anterior shoulder dislocation. This is 12:16. We'll meet at 12:25. Okay. Chal. Thank you. Hello. Break. All right, all right, all right, all right. So now we will be discussing about the anterior shoulder dislocation. So what is the mechanism of anterior shoulder dislocation? Let's understand first of all. So the very important thing, the mechanism of anterior shoulder dislocation. See, the mechanism is fall on an outstretched hand with the shoulder abducted and externally rotated. So it is push only, but with shoulder abducted, and it should be externally rotated. So abducted shoulder and externally rotated. Abducted and externally rotated causes anterior dislocation. Okay, anterior dislocation. Or this is first, or it can be a direct force which is going to push, direct force that is going to push the humerus out of glenoid cavity, pushing the humerus out of glenoid cavity. Direct force that pushes the humerus out of the glenoid cavity. Okay, so the head of humerus is going to come out of the glenoid cavity and it is going to lie anteriorly. Okay, so understand, this is the definition, that head of humerus comes out of glenoid cavity and it is going to lie anteriorly. Okay, so what are the different types? So now we will discuss about the different types. So if you ask me about the types, there are three types. One is called as preglenoid, then subcoracoid, and subglenoid. So preglenoid means when your head lies in front of the glenoid cavity. So the head is going to lie in front of the glenoid cavity. And what about subcoracoid? Head lies below the coracoid process. The head is going to lie below the coracoid process. What is subglenoid then? Sorry, it's not subglenoid, subclavicular. That means it is going to lie in subclavicular. Of course, it is going to lie below the clavicle. It is going to lie where? It is going to lie below the clavicle. Okay. After that, what are the clinical features? So if I talk about the clinical features are going to be abducted shoulder with externally rotated, okay, abducted shoulder, abducted elbow, supported with other hand. So this is the classical, very important, supported with other hand. This is the classical and very, very important clinical feature. Abducted shoulder, abducted elbow, supported with the other hand. This is a very important clinical feature. Coming on to the examination. Or you can say after clinical features, we will now understand about the, after the symptoms, we will discuss about the signs. So you do one or two tests, very, very important test. One is called as Dugas test. Okay, which test is this? Dugas test. And other is called as Hamilton ruler test. What is Dugas test and what is Hamilton ruler test? Let's understand. So Dugas test is inability to touch the opposite shoulder. So inability to touch the opposite shoulder is called as Dugas test. What is Hamilton ruler test? So now it becomes possible to keep the ruler, it becomes possible to keep the ruler on lateral side of arm. it becomes possible to keep the roller on the lateral side of arm due to flattening of shoulder. Due to flattening of shoulder. And now this ruler is going to touch. Now this ruler is going to touch the acromion process and lateral condyle of humerus simultaneously. Acromion process and lateral condyle of humerus. Okay, lateral condyle of humerus as well as acromion process. This is called as Hamilton ruler. Yeah, Hamilton ruler test. Okay. So how will you, after examination, how will you do the diagnosis? So in order to diagnose this condition, you have to use something which is called as very simple X-ray, but which view? So of course, AP view is a very good view, but axillary view is also sometimes done and performed for a better visualization. Okay. Coming on to the last second part, that is the treatment option. So what are the treatment options which you are going to perform? So treatment, please understand, we have to sedate the patient, do the reduction because it is extremely painful. Okay, sedation or general anesthesia. Okay, this is something which we have to do. Then immobilization. Immobilization in the chest arm bandage for 3 weeks. Immobilization in the chest arm bandage for 3 weeks. And of course, the shoulder physiotherapy is required. Shoulder physiotherapy is also something which is required. Now, what are the techniques of reduction? So what are the techniques of reduction? So please remember that if it comes to reduction, then we have to understand one is the Kocher's maneuver. One is the Kocher's maneuver and other is called as Hippocrates maneuver. Kocher's maneuver, Hippocrates maneuver. What is Kocher's maneuver? So it is most commonly used maneuver where we are supposed to apply traction, then external rotation, then adduction, and then internal rotation. So the mnemonic becomes ek garam chai ki pyali ho, TEAI. Okay, and what is Hippocrates? So in Hippocrates, the surgeon is going to apply pull on semi-abducted arm. Pull on semi-abducted arm. Okay, right? So keeping the surgeon's feet in axilla of the patient against the chest wall. Okay, so this is how it is done. Now, before I come on to anything else, I'm fond of learning and telling some of the distinction points. Okay, so we will discuss only the names of static and dynamic stabilizers of the shoulder joint. Okay, but before that, let's understand about the complications. So what can be complications? So complications can be divided into two parts, the early complications and of course the late complications. Okay. So if I just tell you about the early complications, it is the associated fracture. Associated fracture of greater tuberosity. Okay, so there are lesser tuberosity, greater tuberosity. So associated fracture of greater tuberosity, injury to axillary nerve. Injury to axillary nerve. An axillary nerve is something that supplies to deltoid. So deltoid muscles will be paralyzed Okay, and there will be loss of sensation from lateral aspect of shoulder. And what about the late complications? In late complications, of course, one is the recurrent dislocations. Okay, so we call them as loose people. Okay, loose people only. Loose, their the shoulder is loose. Okay, so recurrent dislocations are seen in, like for example, in Marfan syndrome. So in Marfan syndrome, we know that the connective tissue is less. So of course, unstable joint is going to be there. Okay. Now, last discussion topic for this. Let's understand now. Hmm. So please understand, we have static stabilizers and dynamic stabilizers. Only the names. So the static stabilizer, of course, is the glenoid labrum, is the capsule of the joint. Then you have got some glenohumeral ligaments. Okay, glenohumeral ligaments like superior, middle, and inferior. Then coracohumeral ligament and some negative pressure. Okay, negative pressure in the intra-articular surface. Negative intra-articular pressure. Then you have dynamic stabilizers. So dynamic stabilizers are the rotator cuff muscles. I always give a mnemonic of SITS. Okay, supra, infra. Okay, so supraspinatus, infraspinatus, teres minor, subscapularis. Okay, these muscles. Then deltoid, biceps, and that's too long head. And then trapezius, traps, serratus anterior. Okay, so these are again important things which you have to understand. Okay, so now very simple small things. Let's understand about the tennis elbow and the golfer's elbow. So before I go on tennis elbow and golfer's elbow, I would like to show you the images for both of them. So what is tennis elbow and what is, so tennis elbow is actually the lateral epicondylitis. Okay, so tennis elbow is lateral. So lateral has got T word. So T for tennis elbow. Okay, and of course the opposite one is golfer's elbow. This is the medial epicondylitis. Okay, and my question to my dear students: what do you mean by student's elbow? Yes, this you will tell me in the comment section below. What do you mean by student's elbow? Okay, so before telling you anything, so good part is that the major questions we are done with, shoulder dislocation and all. So wrist drop and cock up splint I have kept for last. If we'll have time, we will look at the wrist drop and this wrist drop and cock up splint, because this is something which is very well taken care by the anatomy faculty also, wrist drop and cock up splint. So I can what should I do? Okay, I'll wait.
YouTube disconnecting the things.
Okay.
He's back online.
Okay, is it fine now?
Yes, sir, it's back online.
Okay, 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 okay. So students, I was discussing about the Bankard's lesion. So please understand, this is Bankard's where you have anterior inferior glenoid labrum, which is gone. Anterior inferior glenoid labrum is gone, and this is because of repeated anterior shoulder dislocation. Repeated anterior shoulder dislocation. So repeated anterior shoulder dislocation is the cause as well as the complication. It is the cause also as well as the complication also of your Bankard's lesion. Okay, cause and complication of Bankard's lesion. Okay, Bankard's lesion. So yes, Bankard's lesion is an important thing. So yes, I've given you the Bankard's lesion. So we are done with discussing the Bankard's lesion now. Okay, chaliye. Now we will discuss quickly about the tennis elbow as well as the golfer's elbow. Okay, tennis elbow and golfer's elbow. So see here, this is the tennis elbow and this is the lateral epicondylitis, as the name itself telling you, lateral epicondylitis. Now what is important in this is that, of course, because it is epicondylitis, so the clinical features are going to be pain. So they will give you in the exam, there is a pain, there is tenderness on the lateral epicondyle, okay, at the common, yeah, this is important line, this at the common extensor origin, okay, at the common extensor origin. This is something that is really important, common extensor origin. Okay, right? This is important, and the pain is going to increase when we extend the forearm. Okay, so when we extend the forearm, the pain is going to increase. And what is the treatment? The treatment is nothing but you have to give analgesics to the patient, you give NSAIDs to the patient, okay, and hydrocortisone local injection can also be given. Okay, so local injection of hydrocortisone can also be given. Okay, so everything same. Okay, this is lateral, and everything same as the lateral, your same as tennis elbow. Okay, so everything is same for the tennis elbow as well. So both of these things we are done with discussion. Okay, so I think now we are done with both of these things, and next up we have got a fracture scaphoid. Okay, so let me just teach you the next important topic, that is the fracture scaphoid. Yeah. So fracture scaphoid, please understand, is of two types. Initially, I'm only telling you. One is called as crack fracture, where there's only a simple single crack. So this is crack fracture, and the other is called as displaced fracture. Okay, crack fracture and displaced fracture. Coming on to the clinical features. So what are the clinical features? Clinical features. See, remember, it is more commonly seen in young adults, more commonly seen in young adults. There will be pain, there will be swelling at the radial side. Remember, at where the pain and swelling is going to be there, at the radial aspect of the wrist, and then there will be tenderness in the scaphoid fossa. Tenderness in the scaphoid fossa. Okay, right? Now, if they ask you about the location, so remember, scaphoid has got some parts, and out of those parts, one is called as scaphoid tuberosity and other is called as scaphoid waist. So this waist fracture is more common than the tuberosity fracture. Okay, then the what? Then the tuberosity fracture. Got it? Great. Coming on to the diagnosis. Coming on to the diagnosis portion. So if somebody asks me about the diagnosis, just remember we will perform X-ray of the wrist joint. in AP view, lateral view. In all the three views, X-ray of wrist joint is something that is really important. Okay, so very, very, very important. Okay, and then we have to repeat the X-ray wrist after 2 weeks if you are suspecting, if it is suggestive of crack fracture. So if you think it's a crack fracture, it might not be visible in the very first time. So it's always a good idea to do a repeat X-ray. Okay. For example, if it shows, okay, now I will write the management part over here. For example, if it shows that there is scaphoid fracture, what will you do? You will put a scaphoid cast. For how much time? For 3 to 4 months. So for 3 to 4 months, you will do scaphoid fracture. Casting, scaphoid cast. Now, scaphoid cast, what is scaphoid cast? So scaphoid cast is something, it is a cast that extends. Okay, so this is a cast that is going to extend from below elbow to metacarpal heads. From below elbow to metacarpal heads. It is also going to include the thumb up to interphalangeal joints. And the wrist is maintained in dorsiflexion and in radial deviation. It is maintained in dorsiflexion as well as in radial deviation. Okay, right? So this is again important. After applying the cast for 3 to 4 months, okay, after applying the cast for 3 to 4 months, we will repeat the X-ray. Okay, repeat the X-ray. Okay, if the fracture is seen, okay, sorry, a little glitch in this. So sometimes, as I've told you, if there's a crack fracture, it might not be visible at one, okay, not visible at first. So repeat the X-ray at 2 weeks. Okay, and then if it shows fracture, then we have to manage it like a fracture itself. Okay, coming on to the last part of scaphoid fracture, and that is complications. So the complications which are there are avascular necrosis. This is very important MCQ also. Avascular necrosis. Avascular necrosis of proximal fragment. Then delayed union, non-union, because the blood supply is highly at danger of getting compromised here. Wrist osteoarthritis. Wrist osteoarthritis. Okay, so this is the fracture of scaphoid. Okay, coming on to the next topic, that is frozen shoulder. So frozen shoulder. So it is a condition where your glenohumeral joint becomes painful, becomes stiff because of loss of resilience in the joint capsule with adhesions between the folds. Okay, with adhesions between the folds. Now, the good part about its etiology is that it is unknown, whereas diabetes mellitus and preceding traumas, diabetes mellitus and preceding traumas have got a very good risk factor etiology for this. ठीक है, they are at a मतलब very good chances कि भाई डायबिटीज और अगर ट्रॉमा है तो ये हो सकता है, बहुत ज्यादा चांसेस है. Clinical features in early presentation and in late presentation. In early presentation, there can be pain that is going to worsen at night time. There is pain which is going to worsen at night time. There is stiffness, especially when the patient tries to abduct the arm and do the internal rotation. So just remember, Kabir is the mnemonic for this. So Kabir is AB abduction, IR is internal rotation. Okay, and late complication, pain is going to present all the time. Okay, lately the pain is going to be there all the time, and remember, all the movements are severely impaired. All the movements are severely impaired. Okay. Coming on to the management part of frozen shoulder now. Yeah, coming on to the management part of the frozen shoulder, this disease is usually self-limiting. Okay, generally after 6 to 9 months. So basically, we have to do the conservative management only. Like you can give analgesics, you can give the hot fermentation, you can even do the physiotherapy, and intra-articular injections are given. Okay, intra-articular injections of hydrocortisone, they might speed up the recovery. Okay, so these are some things which can be tried in the frozen shoulder. Okay, frozen shoulder, right? So frozen shoulder is something that's again very important, and I have told you this. Okay, um all right. So let me just go through the comment section, and let me just see if there are some other important things which are left so I can teach you. Otherwise, I'll discuss the MCQs which are there, and then we will finish up the lecture. Okay. All right. So now let's understand some of the important MCQ points, and then we will finish up the lecture. Radial nerve we will cover either with the nerves or we will see list. Okay. So Benkart lesion is done. Chiliazzi's fracture is also done. Okay, let me just okay, so Benkart, one second. Benkart is done. Giliazzi's is done. Okay, these things are remaining. I'll teach you. Tennis elbow done. Golfer's elbow done. Frozen done. Barton's done. Schoffer done. This anatomy we are not going to discuss. Scaphoid fracture is also done. Okay, ठीक है. So basically, Hill-Sachs lesion and pulled elbow. These things are important. Let's understand one by one. Okay, so pulled elbow. Let me just see if I've got the image for pulled elbow. Yeah. So what is mallet finger? It is the extensor tendon torn. Okay, this is a question which has been asked. Mallet finger, so E and T, E for extensor and T for tendon. So this is an important MCQ, and I have taught you what is mallet finger, extensor tendon which is torn. Okay, mallet finger. Anterior dislocation, yes, of course, I've discussed in great detail. So can you see this is the humerus, and this is coming out of the glenoid cavity and आगे की तरफ आ रहा है. ठीक है. Then Schoffer Barton's, we are done. Coming on to the Hill-Sachs lesion. So what is Benkart lesion? So Benkart lesion, I have already told you, that means there's going to be a break. Can you see Benkart means what? Benkart means that you have got um, एंटीरियर इंफीरियर ग्लिनॉइड लैब्रम का लीजन है. ठीक है, एंटीरियर इंफीरियर ग्लिनॉइड लैब्रम लीजन है. ओके, एंटीरियर इंफीरियर ग्लिनॉइड लैब्रम लीजन है, जिसको हम लोग बेंकार्ट लीजन बोलते हैं. बट व्हाट इज हिल-सैक लीजन? व्हाट इज हिल-सैक लीजन? हिल-सैक्स में क्या होता है? यू हैव गॉट what does Hill-Sachs lesion mean? So Hill-Sachs means your greater tubercle of the is also going to get damaged. Okay, so greater tubercle is also going to get damaged in the your your Hill-Sachs lesion. Okay, so just 1 second. Okay, so not greater tubercle, I should write that it is the postero superior. Okay, posterolateral aspect of 1 second. So posterolateral aspect of humeral head. Posterolateral aspect of humeral head is going to show you which fracture? It is going to show you the compression fracture. Compression fracture of posterolateral aspect of humeral head. That is called as Hill-Sachs lesion. Okay, this is called as Hill-Sachs lesion. So I've told you mallet is the extensor tendon, and if it is the flexure tendon, this is called as jersey finger. Okay, this is called as which finger? Jersey's finger. That is the flexure tendon. Okay, that is the flexure tendon. So jersey finger, mallet finger, Hill-Sachs, Benkart. Yes, coming on to this. Now, please understand what is going to be there in nursemaid's elbow or elbow subluxation. So this is the normal elbow joint where there is humerus, this is radius, this is ulna, this is annular ligament. Okay, but in elbow subluxation, like for example, if you pull the arm of the elbow like this, what is going to happen? What is going to happen? This annular ligament gets displaced and comes in between the radius and the capitulum of the humerus. Okay, displaced annular ligament. This is called as subluxation of the elbow and nursemaid's elbow. This is called as subluxation of the elbow. Okay, and nursemaid's elbow, where the annular ligament is getting displaced and it is going to occupy the space between the capitulum of the humerus as well as the radius. Okay, capitulum and the radius. This is nursemaid's elbow. This is what this is called as nursemaid's elbow. Okay, so I think I have discussed now with you the Hill-Sachs lesion also, the pulled elbow also, the mallet finger also, the jersey finger also. Okay, so we have discussed most of the things, and now we will discuss the boxer's fracture. Okay, just a little okay, just a little of boxer's fracture because it has been asked like 1 2 times, so it's my duty to teach you about the boxer's fracture. Okay, so boxer's fracture is the fracture at the neck of the fifth metacarpal. Okay, fracture at the neck of the fifth metacarpal. Okay, now it is a transverse fracture. It is at the neck of the fifth metacarpal with the volar angulation. Okay, with the volar angulation. Okay, and please remember it is the most common type of metacarpal fracture. It is the most common type of metacarpal fracture. Okay, so last homework for you guys, and after this we will wind up the session. Please let me know in the comment section, what do you mean by Bosworth fracture? Okay, please let me know in the comment section, what do you mean by Bosworth fracture? Okay, and I'll give you a hint that this is not of a upper limb fracture, but it is a lower limb fracture. It is a lower limb fracture. Okay, so just let me know, what do you mean by this fracture? And with this we are done with all the important things, whatever it was necessary for upper limb. Okay, Giliazi, Montegia, all these things are done. Green stick we did yesterday. um yeah, and then hill sacks I have told you. um Yeah, okay. Then one more little MCQ. What do you mean by Holstein-Louis fracture? So what is Holstein-Louis fracture? Holstein-Louis fracture is the oblique, is the displaced fracture of shaft of humerus, resulting in entrapment of which nerve? Radial nerve. Okay, resulting in entrapment of radial nerve at the junction of upper two-third and lower one-third. Upper two-third and lower one-third. Okay, upper two-third and lower one-third. Okay, so again, important fractures, and yes, we are done with the fractures now. Okay, some one word important things. Let me just ask you, or let me just write you, Phelan's test. Remember, Phelan's test is done to see the carpal tunnel syndrome. Okay, to see the carpal tunnel syndrome, we perform which test? We perform the Phelan's test. Okay, Phelan's test. Then after that, you have got Tinel's sign, again positive in carpal tunnels. Okay, Tinel's sign again for carpal tunnel. Then you have got Durkin's test. Okay, again for carpal tunnel. Okay, these are important. Allen's test, that is to check the patency of vessels. Okay, patency of vessels. Okay, so these are really important things. So I have tried to inculcate all these things, and I hope that everything is done. Okay, yeah. So Kohli's, okay, just one word. Okay, leave it. So just remember, and I sorry I forgot to add the picture. Just remember Kohli's cast versus scaphoid cast. So scaphoid cast, I have told you in a great detail that the scaphoid cast is something that is going to have cover the thumb. Okay, so scaphoid cast is also called as glass holding cast, with the thumb being covered, whereas Kohli's cast is something that is also called as handshake cast. Okay, and the thumb is going to be free. So how to remember? Remember, if you want to remember like this, if you want to shake hand with Kohli, King Kohli, Virat Kohli, your thumb should be up, thumbs up. Okay, thumbs up करेंगे तभी जो है विराट कोहली साहब आपको क्या करेंगे? हैंडशेक करेंगे. ठीक है, समझ में आ गया? चलिए, very good. And now we will end today's class, and thank you so much for joining. We will see you tomorrow. Tomorrow's timings, I'll let you know in the Telegram. Mostly it will be morning session only, 10 a.m. session, and if not, then it is going to be the 4 p.m. session. Okay, that I will definitely tell you. Okay, Chali. Thank you so much, and God bless you.